Hello, and thank you for joining the National Pancreas Foundation and viewing our webinar. My name is Jenny Pagel-Guile, and I am the Executive Director. The mission of the National Pancreas Foundation is unique in that we focus on all forms of pancreatic disease, providing support for the medical professionals, the care providers, and the patients. Through our work, we have awarded over $5 million in research grants, provided endorsement for centers of excellence across the country, and provide over 30 programs for community members, medical professionals, in addition to just this webinar. First, I would like to share some more information about other opportunities to be involved with the National Pancreas Foundation. If you are a runner or know someone that is, we offer bibs and fundraising opportunities for various events across the country, be it marathons, half marathons, or those coveted bibs. Additionally, we have many more events that change, and they can be found on our website under the events calendar, pancreasfoundation.org/events. This could be a gala, a webinar, or a community chapter event. Feel free to follow along and sign up for our webinars on our website as well. Also, if you're looking to take a more active role, we have chapters across the country. Currently, we have approximately 30 chapters in many states. These chapter volunteers are vital to our grassroots opportunities. They table at health fairs, different community events, and share information. They host Pancreas Bowl events or other fundraising opportunities. They serve as advocates at the local, national, and state level. And they also provide other resources to our community members by being a voice of reason and also a peer in the community. If you'd like to reach out to Cheyenne to learn how you can make a difference in your community, her email is on this slide as well. Also, to stay up to date on the latest information, follow us on social media. We are found on Facebook, Instagram, X, and also on other forms as well. This webinar, Necessary and Sufficient, Best Practices in Exocrine Pancreatic Insufficiencies, is hosted by Dr. Bradford Chon. He is an assistant professor of medicine and director of the pancreas program at the University of Chicago. As a medical pancreatologist, he leads multidisciplinary conferences for pancreatitis and pancreas visceral pain. His research focuses on social detriments of health in pancreatic disease and disparities in cancer care delivery. He is active in building coalitions with local and national organizations to enhance best practices in pancreatitis and early detection in pancreatic cancer.
Well, thank you to Jenny for the warm introduction, and thank you to the National Pancreas Foundation for inviting me to speak on EPI. So we'll just discuss the pathophysiology and complications of EPI. We'll review the workup and diagnostic modalities for EPI, and lastly, highlight best practices for pancreatic enzyme replacement therapy. We know that pancreatic enzyme output is an important part of digestive capacity, and we do see a spectrum of exocrine pancreatic dysfunction before EPI occurs. Digestive capacity is a combination of pancreatic and extrapancreatic digestion with upregulation of extrapancreatic lipolysis to compensate for pancreatic dysfunction. But we know that this is not quite as robust as kind of the body's compensation for proteins and carbohydrates, and that concomitant conditions such as SIBO, celiac, rapid intestinal transit can all negatively impact normal fat digestion. It's important to recognize that while EPI is often mediated by loss of intraluminal available pancreatic enzymes as a result of parenchymal destruction, there are other mechanisms in the setting of an intact pancreas parenchyma that can contribute to enzyme loss and affect normal fat digestion. Examples of parenchymal destruction include conditions such as chronic pancreatitis, acute necrotizing pancreatitis, pancreatic cancer, and pancreatic surgery. Patients can have decreased endogenous stimulation of the pancreas and secretion of enzymes, whether it be the celiac or Crohn's disease. Zollinger-Ellison syndrome can cause intraluminal inactivation of enzymes, and patients with prior GI surgery can be prone to asynchrony with gastric emptying and consequently fat malabsorption. So it's important to recognize that treating the underlying condition should be part of the mainstay treatment of EPI. EPI can have important clinical consequences for bone health and nutrition. Various studies, including a large cross-sectional study from the PERT consortium a few years back, found that up to 70% of patients of chronic pancreatitis had either osteopenia or osteoporosis on their DEXA scan, with over 60% of patients having vitamin D deficiency. Unintentional weight loss and sarcopenia are other adverse outcomes that have been linked to EPI. Steatorrhea, or fat in the stools, is one of the hallmark symptoms of EPI, but this can be tricky. As you'll see on the left figure, on the x-axis, once the lipase output goes below 10%, the fecal fat on the y-axis, which correlates with pancreatic dysfunction, increases dramatically. So the pancreas has this large reservoir capacity with late development of steatorrhea symptoms. This understanding helps guide our dosing recommendations for enzyme replacement. So we generally start with 72,000 units of lipase with meals, which we believe is near adequate to produce enzymes for digestion. So what are the available tests to diagnose EPI? The fecal elastase is probably the most readily available, and when used in the proper context can be useful. This test is more sensitive with more advanced disease. The fecal elastase, a normal result in a low prevalence population, it's unlikely to be EPI. But consider the following, that in meta-analysis studies, there's been a high false positivity in low prevalence population, there's up to 11%, as well as high false negativity rate of up to 9% in high prevalence population. So we need to ensure that this test is interpreted in the appropriate clinical context. But this test is widely accessible. It's easy to use. As for other tests, well, there is the timed fecal fat test. This is a 48 to 72-hour stool collection test that can be accurate for fat malabsorption, but it has its limits. It's a cumbersome test. We ask patients to go on a high fat diet of 100 grams of fat daily for 2 days. And then it's an onerous, multi-day stool collection. And we do require patients to hold their pancreatic enzyme replacement, ideally a week before testing. Now, there is this other test called the endoscopic pancreatic function test, where during an endoscopy, they collect pancreatic duodenal juices in response to IV secretin stimulation at timed intervals. They're looking at the bicarbonate secretion, and that can give us kind of an indirect kind of measure of pancreas function. It's a dynamic measurement. If you're doing an EUS at the time, you can also assess pancreas morphology, as well as other intraluminal causes of diarrhea. Drawbacks are that it's invasive, it's costly, and it's only available at certain centers. So EPI diagnosis still to this day relies on a combination of symptoms and history, cross-sectional imaging, and stool testing to kind of aid in our diagnosis. Can pancreas morphology be used to diagnose EPI? Well, no, not directly, but EUS can be used as an indirect method to predict EPI in patients with chronic pancreatitis, for example. We've seen with a prior study that the probability of EPI with maldigestion increases linearly with the number of EUS criteria of chronic pancreatitis. So while EUS is not a diagnostic test for EPI, it can be one tool to assess if someone may be at higher risk potentially for EPI. If the diagnosis of EPI is correctly made, then you want to think about proper timing and administration of enzyme replacement. It's important to remember that pancreatic enzyme delivery into the duodenum increases rapidly in response to a regular meal and peaks within the first postprandial hour. To maximize mixing then, we counsel our patients to take the first two bites into the meal and then take the first capsule. If a second capsule is needed, take the second capsule halfway into the meal. If they take a snack, encourage them to take a capsule with that as well, in the same way. Proper recognition then of high-risk patients and subsequent treatment remain major practice gaps in the field. This is a study back in 2020 looking at patients with chronic pancreatitis and pancreatic cancer and who was filled a prescription for enzyme replacement and who was on adequate dosing. In the chronic pancreatitis group, only 30% of patients were fulfilled a prescription for enzymes, and only 9% was an adequate dose. Patients with pancreatic cancer were even worse shape. Only 22% of patients had a prescription filled for enzymes, and a meager 6% were on adequate dosing. So we know we have much a ways to go on these areas. This was a nice review article from Phil Hart that provided a fishbone diagram looking at the different management points and potential pitfalls for EPI. There are many, but the biggest opportunities to improve practice in my mind are, one, identifying, diagnose the patients correctly, and then two, treating and adjusting therapy appropriately. So these are some kind of best practices for management of EPI. So one is starting dose for pancreolipase. So with enzymes, we generally recommend a starting dose of 72,000 units lipase with meals. If they take a snack, a 36,000 units dose is appropriate. And then we want to assess response to treatment. And the things that we're looking for is weight gain, improvement of steatorrhea, and fat-soluble vitamin deficiencies. Rechecking a fecal elastase to measure treatment response is not recommended. When we have patients that are quote unquote non-responders that aren't clinically improving, one of the first things that we ought to do is assess timing of administration of the enzymes. Many of the patients who come to me and are not responding to therapy, they're taking their enzymes before their meals, before they've had a chance to have the enzymes mixed. And so we encourage the patients to take the enzymes with meals, and they often see a clinical improvement. In cases where folks are properly administering the enzymes but still not having significant improvement, we'll generally recommend adding a PPI as well. The thought being that inhibiting stomach acid secretion helps avoid the bile acid precipitation and helps avoid lipase inactivation. This thereby leads to lipase release within the proximal duodenum and potentially improves the therapeutic efficacy of the enzymes. So we'll often do this in inadequate responders. Now, if patients are taking the medication on a good dose, administering correctly, they're on a PPI and they're still not having good relief of symptoms, then we do want to consider alternative etiologies. We want to think about, could there be a concomitant SIBO? Has patient been tested for celiac? Is there a component of rapid intestinal transit? These are the diagnoses that we want to consider in these cases. And then from a disease kind of preventative standpoint, given patients' risk for osteopathy with EPI, I generally will check fat-soluble vitamins once a year. I'll also check a DEXA scan every 2 years. While this isn't strictly guidelines, given their risk for osteopathy, I think this is a reasonable practice. So this is a bit of an algorithmic approach to EPI. As we stated before, much of it is kind of identifying through history, exams, imaging, who is the highest kind of risk for patients likely to develop EPI. So patients with chronic pancreatitis, complicated acute pancreatitis. I should make a note here that, with more recent studies, we're finding that even patients with uncomplicated acute pancreatitis are susceptible to developing EPI. And certainly patients with pancreatic cancer, history of pancreatic surgery. So these patients, if they have clinical symptoms of steatorrhea, weight loss, or fat-soluble vitamin deficiencies, it's very reasonable to go on to pancreatic function testing, either fecal elastase testing or fecal fat. Now, while there is not clear consensus about what that fecal elastase threshold is, I think for a patient in this high-risk group who has clinical symptoms, and a fecal elastase of 100 or less, I think is a reasonable threshold. If they have positive testing and in the history to fit, then appropriate to initiate pancreatic enzymes and then assess response. So as we talked about, looking at clinical parameters of weight gain, improvement of steatorrhea and fat-soluble vitamin deficiencies, and then moving there on after to dose escalation if needed. So some of these patients that come to me, they're on 36,000 units. I will escalate that up to 72,000 units if they're not having a relief. Again, making sure that they're taking it at the appropriate timing with the meals, add a PPI if inadequate responders, and then thinking about alternative causes if they continue to have symptoms. So take-home points, have a high degree of suspicion for EPI in your high-risk groups. So chronic pancreatitis, complicated, and I would also say uncomplicated acute pancreatitis, pancreatic cancer, pancreatic surgery. Consider alternative diagnoses in your low-risk groups. So think about celiac, SIBO, rapid intestinal transit. Think about bile acid diarrhea as well. Fecal elastase is most sensitive for detecting severe EPI. And last but not least, patients with EPI are at increased risk for vitamin D deficiency and osteopathy. I want to thank you very much for your time and on behalf of our team at UChicago. Thank you.